Hello, and welcome to our presentation today, Athletic Trainers and the Patient-Centered Medical Home. I'm Ashley Long, the Concussion Clinic Coordinator at Mount Olive Family Medicine Center in Mount Olive, North Carolina. I have nothing to disclose, no conflicts of interest in this presentation. I wanted to let you know what our objectives are today. We're going to start by going over some global concepts of healthcare, including the Affordable Care Act, and the current challenges that exist in our healthcare system. We'll go specifically into issues of rural underserved patients and the publicly insured. And then we'll talk about the ways that athletic trainers can assist to help meet these challenges and participate in the patient-centered medical home with care coordination and an athlete-centered medical model. So we'll get started today talking about some global concepts of health. Several years ago, the NATA made a concerted effort to start getting all athletic trainers in the mindset of us being healthcare providers. And we are constantly in effort to become integrated into the healthcare system in a medical model. So over the past few decades, the view of ourselves and the view of us by other healthcare providers has changed. And in many examples, we're considered integral members of the medical care team. And so we've had PR campaigns and Athletic Training Month initiatives to really get that word out that we're healthcare providers. We're constantly working on achieving, consistent third-party reimbursement and becoming, full members with a seat at the table of the healthcare team. But I think it's important that athletic trainers understand the challenges and the current climate of healthcare so that we can speak the language and speak to the values and the challenges of our healthcare system. So we need to answer the question, how are we relevant to our current healthcare system? The Affordable Care Act became effective several years ago, and we're still working that out at the federal level. How do we get healthcare coverage to as many people as possible in a cost-effective way where it's a sustainable model? And the goals of the Affordable Care Act include expanding coverage to as many individuals as possible, controlling healthcare costs because the costs were out of control and unsustainable, and we still are having issues in that regard. How do we improve healthcare, and how do we improve its delivery system? So goals of the Affordable Care Act are along those lines. Improvements that the Affordable Care Act aims to address would be a team approach, and this shift from siloed care to integrated care has really taken off, and we've seen the effects of it in a practical way. Another key word is coordinated care, so that providers are in communication with one another, that there aren't duplicate tests going on or inefficient care, and that care is understood by the patient, and that we provide an increased access to health insurance for those that either fall in the gap where they don't qualify for public insurance, but private insurance is too expensive, and other examples of those who have a hard time accessing health insurance. So overall, we want to increase the access and quality and decrease the cost. So the current challenges, we're going to talk about coverage, cost, priority populations, and specifically adolescents. So there are a shortage of primary care physicians, and that's a common topic and probably a pretty well-known fact. But I think more than just a shortage, we have a maldistribution. And anytime that there's a challenge, our profession should look at, well, what's our opportunity? So for example, I work at we operate our concussion clinic out of a rural health center. And so there's very little access to concussion care, specialized care, or sports medicine services in our region. Now, if you go to a more metropolitan area, those things are abundant. So when I moved here, I saw that, well, there's nothing like that here. So there's an opportunity to provide that. Adolescents have decreased health maintenance exams. So we're talking about those well child checks that are critical. We have when we have decrease in those, we're not providing the preventative care, the upstream measures, and then we end up with people just coming when they're sick. And so seeing the healthy, well child is just as important as seeing the sick child. And we know that that's an obstacle. Think about the athletic trainer in the setting of the high school or the secondary school, and the amount of contact that we have with healthy kids and the education and prevention that we can do with those kids. Adolescents have an increased burden of access to healthcare. So they hold all the other obstacles that adults do, plus they're dependent for transportation, for financial support, and otherwise. So they're a particularly vulnerable population when we're thinking about who has decreased access to healthcare. A lot of our adolescent patients may have no network or no primary care provider. And this becomes important. Our primary care providers are essential in this model, in this healthcare system, and we need to be there to support them, to provide the care. But when that primary care person, that quarterback of healthcare, the center or main assistance to the patient is not established, then that patient can really kind of drift off into not being monitored, not having those annual wellness checks, and not having appropriate vaccinations and otherwise. We know that priority populations have decreased care coordination, and so our most vulnerable populations also have less effort surrounding them to make sure that their care is efficient and complete. Uninsured youth have increased unmet health needs. So those of you that have worked with this patient population where you're working with uninsured adolescents, you certainly know the challenges that you encounter very quickly when they have some sort of healthcare need, let alone preventative wellness exams, and you're trying to access care, assist them in accessing that care. Primary care physicians need increased connections with the community organizations for outreach. So this is a push on their end to not just stay within their offices, but to connect in the community, whether this be for food insecurity and working with local entities that assist people in getting nutrition, whether it be social services, working with that, or at the schools. And this is a perfect match for a relationship where you can be the eyes and ears for that primary care physician and partner in the healthcare of that child. So we're located in North Carolina. I have an example from our state. There's certainly data on your state out there if you look for that. This is a map showing persistent primary care health professional shortage areas. So HPSAs, or health professional shortage areas, are a very common measure that is used for various grant agencies or designations of need, where we're looking at what's the amount of land mass, what's the total population, and how many providers are there to serve the population. So you can see here on this map that we have several counties in our state, and they tend to be either very in the northeastern part or in the very western part, which is mountainous, of our state, where the whole county is persistently short in healthcare providers. Other counties, the gray counties you can see, have partial areas where they have that shortage. So if you're interested in making an argument for your program or for increased athletic training, these data can be very helpful in backing you up to say, you know, we live in a place where the population already has a shortage of healthcare providers, and having an athletic trainer there is going to increase access, which is a really important buzzword right now and an important aspect of care. So the insurance environment in your state is going to vary. In North Carolina, Blue Cross and Blue Shield of North Carolina insures over 85% of our population that has private insurance. So they're very persistent, and we see many, many people that are insured by Blue Cross and Blue Shield of North Carolina. So again, speaking the language of who you're trying to partner with is going to be important. And so Blue Cross Blue Shield of North Carolina published their own materials that said, these are the problems that we see in healthcare. And then as athletic trainers and as a business owner, we say, okay, well, where are the places that we can help address the problems that you're identifying? So for example, lack of preventative care. When athletic trainers are in place, we provide many aspects of preventative care, anything from preventing catastrophic injury to preventing chronic disease, to preventing acute and chronic injuries. So, you know, certainly we can provide data to support that, but we're giving a clear and evident solution to one of the problems that they've stated themselves. Other examples are inefficient care, overtreatment, unhealthy lifestyles, obesity, ER overuse, which is a great one for athletic trainers to pose their value and worth in. You know, the amount of times that we can prevent someone from going to the emergency room when it's unnecessary. That's a huge cost savings. And in this example, Blue Cross and Blue Shield of North Carolina would be very interested in hearing what the cost savings could be with the implementation of an athletic trainer. And then they also address uncoordinated care, for that person who's kind of floating around the system. Providers aren't speaking with one another, and the care becomes very expensive and less effective. In our clinic, about 50% of the patients that we see are publicly insured. So this is Medicare and Medicaid. Parents of children with public insurance are more likely to report poor communication with their health providers compared with those with private insurance. So we know that there's an issue with communication and understanding with our publicly insured patients. That's documented. So this is an area where we certainly can assist these patients in connecting and communicating with their healthcare providers. In North Carolina, in particular, there are numbers that show that over the years, our numbers of children enrolled in Medicaid are growing by the hundreds of thousands. And so this data is available to you as well for your state, and can also be very supportive when you're trying to make a point of how you can decrease cost and address a specific issue in the population that exists for a growing number, in this case, of children. Traditionally, publicly insured patients have received decreased quality of healthcare. So that's also supported in the data and the literature. A shortage of providers that will accept Medicaid. I've seen this anecdotally in our community where we have school nurses and other people in the community reaching out saying, I cannot find a provider that will accept a child with Medicaid. And because the reimbursement rates are lower, we see that happening. And so we know that there is an issue with providing access to care because these children are denied the access simply because of their status with Medicaid. So again, a perfect place for us to step in and assist. Only 56.8% of children 0 to 18 years old enrolled in Medicaid received at least one health check screening for preventative care purposes in 2011. So that's an interesting fact. They're looking at about only half of those kids on Medicaid receive that annual wellness check. And I think there's lots of ways, hopefully they're pretty clear, that we can integrate into that wellness perspective, whether it's navigating the patient to the primary care to be sure that they're getting that thorough wellness exam, or if it's integrating some of those measures and factors into our screening processes and then coordinating care for those children that we see are outside of normal limits, whether it be blood pressure, vision, etc. An average of a 22-day longer wait for an appointment exists for publicly insured patients compared to privately insured children. And that's significant. And we can look at outcome measures of that, and clearly we're going to see decreased positive outcomes for the patients who have waited so long for an appointment. So all of these facts and these resources are building up the case for how we can address real issues that the government is dealing with in trying to provide healthcare to those who are publicly insured. With that annual wellness or that health maintenance exam, adolescence rate is 34% compared to 59% for 3 to 6 year olds. So we know that during those important vaccination years and that stopgap at kindergarten where they require vaccinations, we have a very high percentage of people bringing their children to the office to receive that well child check. Once they get past those vaccination years, the numbers basically drop in half. And the health maintenance exam is critical in primary care. And so if we can address either navigating the patient to the primary care or assisting in those measures through a school-based health system or through our own pre-participation physical exams and integrating that into that wellness exam, teaming up with local physicians, this can be very helpful. Adolescents rarely receive recommended levels of preventative care through annual primary care visits. So I think, again, we're in perfect position to address this concern. Now, we want to talk about a change in the philosophy from fee to service to quality and efficient care. This has been going on for at least a decade, where we've said, no longer is it efficient for us to have a fee for service, which is just the more that a provider does, the more they get paid. And that incentive would then become financial versus what's in the best interest of the patient. And we want everyone to win. So we want reimbursement rates to be acceptable for providers, but we also want patients to receive the appropriate amount of care in an efficient way, because it's not a vacuum. So if somebody is receiving inefficient care or too many tests or too many scans, then that's going to affect down the chain that somebody else can't get in. So we have shifted from that fee-for-service to a patient-centered medical home where the effort is around quality and efficiency and appropriate care that's based in evidence. So the relationship-based primary care that meets the individual patient and family's needs, preferences, and priorities. So this is a tall order. We're treating our patient at the center, and we're recognizing what their needs are, what their preferences are. So, not just what the provider thinks, but what the patient also prefers, and what the priorities are of the patient. And different patients have different needs when it comes to social needs, economic needs, and then those need to be considered when you're making those healthcare decisions. So the patient-centered medical home has many components to it. We'll talk about how you become eligible and qualify for it, and then what the benefits are for the patient. So with the patient-centered medical home, We have case management, which is when you're bringing individual in or resources in to help make sure that the case is being supported and provided in efficient and effective ways. People aren't falling through the cracks and people have the support that they need. Chronic care, so folks with comorbidities and chronic conditions are very costly to the healthcare system and very time consuming for providers. So we initiate in the patient-centered medical home specific programs just for those patients with chronic conditions like diabetes and hypertension. We look at comparative effectiveness and always are practicing evidence-based healthcare, managing disease, that we have integrated health IT, and that we can communicate across systems so that we can provide the best care for the patient, looking at what their test results are or what another provider saw them for, what other medications are they on. So being able to communicate clearly and quickly in that way is important. Incentives for providers and for patients towards wellness, integrating the Medicaid and Medicare patients into the system and not discarding them because of reimbursement rates. And then really putting that patient in the middle and the care is directed by the physician. So these are all the values of a patient care centered medical home, and athletic trainers can fit nicely within this. The 5 main functions of a PCMH are comprehensive care, coordinated care, patient-centered care, accessible services, and quality and safety. So the list that I was saying before will fall under these categories. And I highlighted coordinated care, patient-centered care, and accessible services because these are really areas where athletic trainers can assist and provide value to the healthcare system. With care coordination, it's defined as the deliberate organization of patient care activities to facilitate appropriate delivery of healthcare services. I find myself doing lots of care coordination with our patients. When we see a concussion patient, for example, part of what we do is a return to learn plan. And I'm working directly with the counselors at the school who are charged with the education and accommodations of children in the school to provide that education accommodation that the concussed patient needs. Also, we may refer the patient, and I'm communicating with therapists who are doing vestibulo-ocular therapy or cervical soft tissue therapy for the concussed patient. And also communicating with the parents of these adolescent patients and making sure that the patient is progressing and that the outcomes are what we desired. This doesn't just have to be, I speak from a concussion perspective, but even if you're working at the secondary school, you are doing lots of care coordination for your patients, getting them to where they need to go, monitoring their progress, and advocating for them when things aren't going quite right. So we've shifted that patient to the center of the care instead of the provider. And that's just a paradigm shift that the healthcare system has taken. There are incentives for medical centers to become accredited as a patient-centered medical home. So the National Committee for Quality Assurance is the accrediting body, and they give criteria, and different medical centers can qualify at different levels as a patient-centered medical home. North Carolina happens to rank second for the number of providers to gain accreditation for PCMH. Mount Olive Family Medicine Center, where I work, is a PCMH at the level 3. And so we have a lot of we are in a rural place. We have a lot of publicly insured patients, and we have grant-funded programs that assist those patients. For example, we have a prescription assistance program that helps patients access medication when otherwise they couldn't afford it. We have a nurse care coordinator for chronic care management, whereas if we have a patient that's over the age of 65 and has 2 or more chronic diseases, they receive regular phone calls from this nurse, and then she connects them to resources, whether it be through their physician or through the community, to help them become well. And then private insurers like PCMH, because it saves them money, it provides a higher quality of care, it helps patients comply with their doctor's orders, it provides more support for patients that need more support, and the outcomes are better. So when somebody is designated PCMH, there's a financial incentive that goes along with it. When we think of athletic training, we fit beautifully into this model and have actually been providing a patient-centered model ever since the inception of our profession. We provide efficient care, mainly because we have to. A lot of times we don't have all the resources that we need, and we need to be efficient. All of our care is patient-centered. We've never had a fee-for-service model, so we're always there just to serve the patient. There's no other incentive otherwise. We are highly accessible, and we oftentimes are the care coordinators for our patients. When we place the athlete at the center of that medical model, this concept of a school-based sports medicine team becomes very apparent and can be an excellent provision of healthcare for the secondary school athlete. When we talk about accessible services, school-based health centers have some great research out there to support their value. This goes beyond just your classic school nurse. We have several school-based health centers in our county, and I work closely with those providers. So, for example, in our school-based health centers, these are located in our schools with very high percentage of low-income students. The students enroll in they were called WISH centers, it's an acronym, and they have access to a nurse practitioner 2 days a week, to an RN every day of the week. They can provide vaccinations, well child checks, pre-participation physical exams, and medication monitoring. And so this is great access for the student, those of which who have many obstacles otherwise and will probably not be receiving any preventative care if they didn't have access at school. So they're providing that basic primary care. All kinds of barriers are overcome by this accessibility of the school-based health center. You can see them listed there, but in this particular research article by Guo and colleagues, we can see that they save Medicaid $35 a student, which might not sound like a lot, but when you start adding that up over time, it can be a net benefit of over $1 million over 3 years. And so now we're starting to get people's attention on how can we do school-based health the best, which providers should be integrated into it, and how can we save money. So I would argue that a school-based health center is a perfect place for an athletic trainer to be integrated, working with colleagues so that everyone's working at the top of their scope, and we have access for students from the minute they get to school to the time that they leave. Now, this question of how we can provide access to care is being asked and funded. So the Agency for Healthcare Research and Quality provides opportunity for a grant improving primary care and clinical outcomes. And they are asking the question, how can we rethink and redesign healthcare? How can we connect the clinic to the community? How can we provide self-management support? So, keeping people out of the emergency room and out of the clinic when they don't need to be there, but making sure they get the care when they really do. And how can we increase that care coordination? So what are some new models? What's the role of the clinical team? So which multiple providers can we put together working together? And what are the community resources to improve the delivery of health? And with that athletic trainer on campus every day, it's an excellent opportunity for having access to a healthcare provider. So, this is just one example of a government-funded grant agency that's asking this question: how can we improve this? What are the effects? What are the outcomes? And are they best for patients? The school-based sports medicine team is largely unexamined. There's not a lot in the literature about it. It would be great for people to start putting a value assessment, and some individuals have. I know we have great people leading these large healthcare-based outreach programs where the athletic trainers are working in the schools. We really need to start publishing that data in larger volumes about the value that they're bringing to healthcare by providing these services. And what are the improved patient outcomes? So I know that we've had this initiative in the past, and we need to continue to build sound arguments on the effectiveness of athletic trainers to the healthcare system when they have that access to specifically the adolescent patient. When we integrate the athletic trainer with primary care, there's some steps that we need to take to make sure that that process is good and that it's effective. So one would be formalized introduction. So educating the primary care provider about athletic training. We all know that different providers and different disciplines come in with varying knowledge and understanding of our profession. We've all had that conversation multiple times, and that's where you start, just educating them about the scope of what you can do and what value you can bring to the team. And then developing communication and a referral plan. So that might include some telemedicine. It may include, visits or communication, either you to their clinic or for them to stop by and see you where you are in the community. And then follow-up evaluation and improvement of the program. How can we help you? I guarantee if you're in a place where accessibility and access is an issue, and you approach a primary care to say, I want to help you get access to these children in the community, and I am a healthcare provider working at the school, they will not turn you away. So it just might take a little convincing, a little legwork, a little education, but it's a natural marriage that once people understand what athletic trainers do, they're very accepting of. I write down the benefits to everybody involved. So obviously to the patient, it's an increased accessibility, increased care coordination, and we are, when you're talking to the primary care physician saying, we're working with you, we want to assist you in meeting your goals and objectives. Physicians now are paid, measured, graded, reimbursed by the outcomes of their patients. So if you're there saying, I want to help you improve your outcomes, they will listen to you. They will look at you as a great partner in resource in that. The benefit to the AT is it provides support in addition to your team physician for the athletic trainer to be treating the patient. So anytime we have good partnerships for physicians, it helps us. And then the benefit to the physician is it increases his or her access to the patient, and he or she now has access to you who's embedded in the community. So it's a win across the board. We know that the cost of athletic injuries, and this is taken from the Agency of Student Health Research, is costly, and that we can be there to either prevent them altogether or funnel that patient, with the correct diagnosis, correct care, and then correct referral. So it's a win across the board. For the patient, obviously more access to care. For the healthcare system and third-party payers, decreased in the cost because it's efficient, effective, and coordinated. And for the provider, to be able to have access to their patient through you is extremely helpful. So how can we be included? How do we include ourselves if people don't even know that we're there, don't know what our scope is? Well, first of all, connecting with the executive directors, the leaders, the physicians at your patient-centered medical home, educating third-party payers about the cost savings. So this requires data and outcome measures and cost measures that you could provide to show the value. Educating your legislators on this. So, for example, our local school-based health systems are supported in part by private donors, in part by public county money, and in part by state funding. And so they see the value in what it provides, and they're willing to support it. This has to be driven by data on what the cost savings and health outcomes are. Developing relationships with other provider organizations, physician organizations, PAs, NPs, becoming allies and partners with them, and understanding what the PCMH is, what the benefits are, and how we can fit into it. So, I gave you a perspective from North Carolina and from our clinic. Hopefully, I gave you enough of a global perspective that you could take that into your state and your setting. But I think the possibilities here are great, and that it takes the athletic trainer advocate to insert ourselves into this model. But understanding the priorities of where our healthcare system is going is going to be critical if we're going to integrate ourselves into that. So I want to thank you for your attention.